Welcome to our ENDO 2024 Diabetes News Conference. We're delighted to have you all in Boston with us today. My name is Colleen Williams, and I'm the Senior Communications Manager at the Endocrine Society. Today's news conference will explore the latest in diabetes research. We're very pleased to have with us Dr. Mojca Genstrel-Sever of the University Medical Center in Slovenia, Dr. Jennifer Titch from the University of Rochester in New York, Dr. Mahesh Umapathy-Sivam of the University of Adelaide in South Australia, and Dr. Carlos Fermin-Martinez of the National Autonomous University of Mexico in Mexico City. Over the next 30 minutes, each speaker will present their findings and will end with a Q&A session. Please note that the conference is being live streamed, and we have many journalists joining us remotely today. Because we are live streaming, it's important for all remarks to be made into a microphone to enable those joining virtually to hear you clearly. Journalists who are attending online will be able to type their questions into the chat at any point during the news conference, and they will be addressed at the end during the Q&A. I would now like to invite our first presenter, Dr. Sever, to speak.
Good morning to everyone. It's a great pleasure to be here. First of all, I would like to thank the Endocrine Society for giving us opportunity to present our research. And I would also like to thank the media and communication team of Endocrine Society for bringing further attention to it. These are my potential disclosure. I'll leave the slides on for a few seconds. Okay, first our key takeaways. Semaglutide improved taste sensitivity in women with obesity, which means that it lowered detection threshold for certain tastings. Improvement in taste sensitivity was accompanied by alternation of messenger RNA of genes involved in taste transduction of sweet, taste bud differentiation, and renewal. And semaglutide increased activation in the parietal cortex in response to the sweet solution dripped directly on the tongue while performing functional MRI. However, our study should be seen and interpreted as proof of concept study, and future studies will clarify whether the efficacy of semaglutide in treating obesity is also a matter of taste. Our hypothesis built upon some previous observational studies and animal models. Some studies reported that individuals living with obesity often pursue tastes as less intense. Populations that are prone to obesity have an inherently elevated desire for sweet and energy-dense foods. Of course, obesity is very complex and heterogeneous disease, and this could not be applied to the whole population living with obesity. Preclinical research provided some interesting insights into the potential direct role of GLP-1 in the gustatory coding. It was found that GLP-1 is locally synthesized in the subpopulation of taste bud cells in the tongue. GLP-1 receptor exists on the gustatory nerve fibers in close proximity to GLP-1 containing taste bud cells. Paracrine GLP-1 signaling is specifically involved in the perception of sweet taste. We were actually amazed of the similarity between the sensation of the sweet molecules within the taste bud in the tongue and the sensation of sweet in the gut. In animal model, GLP-1 was released from taste bud in response to sweets, but not to other taste stimuli. And GLP-1 receptor knockout mice exhibited a dramatic reduction in sweet taste sensitivity. Built upon this background, we aim to evaluate the impact of once-weekly subcutaneous semaglutide 1.0 milligram on taste perception in women with obesity and without diabetes. Primary endpoint was to investigate the effect of semaglutide on taste perception as detected by chemical gustometry. Co-primary endpoint was to investigate alteration of transcriptomic profile of human tongue tissue to provide further insight into the mechanism of action of semaglutide in taste perception. Secondary endpoints included changes in neural response to visual food cues and taste task as assessed by functional MRI. We conducted randomized placebo-controlled single-blind study with 30 women with obesity of average age 33.7 and average BMI 36.4 without any serious chronic illness. They were randomized in 1:1 ratio to semaglutide in placebo group for 16 weeks, including 1 month of fast titration period. The eligibility criteria aim to control for as many covariants as possible that, alongside obesity, could affect taste perception, including sex, age, chronic illness, smoking. And by selecting anovulatory women with polycystic ovary syndrome, we aim to reduce variability in taste perception across different phases of a menstrual cycle. Trial protocol was quite demanding, consisted of 7 visits within a 5-month period. Each woman performed tongue tissue biopsy and functional MRI before and after intervention. The perception of taste was measured by 16 taste stripes consisting of 4 different concentrations of sweet, sour, salty, and bitter substances, and the patient was asked to identify the taste of each taste stripe. The tongue tissue was performed by ENT surgeon at the standardized place, 1 centimeter from tongue apex and to the left. Transcriptomic profile of tongue tissue was assessed as changes in expression level measured by RNA sequencing, and then bioinformatic analysis was performed. The fMRI protocol included 2 tasks. In the first task, subjects were shown a series of calorie-dense, calorie-low food, and non-food cues before and after high-protein enriched nutritional drink. And in the second test, the neural responses to the tasting of sweet solution in comparison to distillated water dripped on the tongue was assessed. The baseline characteristics were comparable in both groups. There were no difference in anthropometric, metabolic, and endocrine parameters between the 2 groups. The results: we demonstrated that semaglutide significantly improved the overall taste sensitivity with the estimated treatment difference of 2.5 points and the sensitivity for all 4 basic tastes. The genes that exhibited differential messenger RNA expression across a multi-tiered analytical pipeline were those that are associated with taste transaction of sweet, taste buds development, renewal, and differentiation. The results from functional MRI scan: semaglutide decreased activation in the putamen in response to calorie-dense food cues. This is an area involved in the reward system, implying less satisfaction due to high-caloric food cues in semaglutide group. In the taste test, semaglutide increased activation in the angular gears in response to the sweet solution dripped on the tongue. And interestingly, GLP-1 receptor have been previously detected in exactly this region in a study on human autopsies. Angular gyrus is a part of parietal cortex which has the integrity role in comprehension and reasoning, including reorienting the attentional system and giving meaning to external stimuli based on stored memories and prior experience. It means that it could recontextualize the peripheral stimuli. The safety profile was in line with the data from STEP clinical program. We observed relatively high frequency of gastrointestinal side effects that were mild to moderate, mostly transient, occurring during titration, and they did not lead to discontinuation of the drug. There were no serious adverse events within the study period. There are several important limitations of our proof of concept study. It assessed only a specific taste in study environment which may not reflect everyday experience. Taste perception can vary significantly from person to person due to genetic, personal characteristics, and experiential factors, limiting the generalizability of our results, because we were really doing with very homogeneous cohort of women. And of course, messenger RNA sequencing has inherent limitations and does not directly represent changes in protein levels or activity. Therefore, we really need future studies that will clarify whether the efficacy of semaglutide in treating obesity is also a matter of taste. By this, I would like to acknowledge to my team, in particular the lead author, Professor Andrej Janáš, and I would, of course, like to thank you for your attention.
All right, great. I would now like to invite our next presenter, Dr. Titch, to speak.
Hi everybody, my name is Jennifer Tisch. I'm a third-year resident in the Internal Medicine Pediatrics program at the University of Rochester. Thank you all for having me. Thank you to my mentors, Dr. McLeod, and to Dr. Fortuna for all of your mentorship and guidance and support throughout this project, as well as to the rest of our team whose hard work has made this all possible, so thank you. I'm here to talk to you all today about the impact of social vulnerability on glycemic control in patients with diabetes in a primary care setting. We have no conflicts to disclose. So why is this important? As of 2021, there were nearly 30 million people living with diabetes in the United States, and the prevalence of this is only predicted to continue to increase. Diabetes and its complications can lead to excess morbidity as well as cost to both patients as well as the healthcare system. Despite advancements in diabetes care and technology in recent years, patients from marginalized communities continue to bear the brunt of diabetes and its complications. And despite these well-known disparities, less is understood about the intersectionality between social vulnerability and race and its impact on diabetes control. So we set out to examine the impact of social vulnerability on diabetes control, as well as to describe the intersectionality between race and social vulnerability on diabetes control. We measure social vulnerability using the Social Vulnerability Index, which is a scale and a scoring system that ranges from 0 to 100%, with higher scores implying greater vulnerability. It's calculated for a given census tract area, and it incorporates various elements of social determinants of health. Here you can see several of the key categories that comprise the Social Vulnerability Index that include things from socioeconomic status to household characteristics, racial and ethnic minority status, housing type and transportation, and several of the categories that make up each of these key components. Within our primary network, we were able to identify around 23,000 patients living with diabetes, and the census level data was used to determine the Social Vulnerability Index for each patient. Ultimately, multivariate logistic regression models were performed to determine the impact of social vulnerability and covariates on diabetes control. So here you can see several of the key categories that make up the social vulnerability index. And you can see that for every 10% increase in vulnerability at each of these categories, there's about a 5% decreased odds that one's diabetes would be under adequate control. Here we looked at patients who identified themselves as being white and Black at each level of the social vulnerability index. And you can see that while social vulnerability increasing leads to decrease in diabetes control, that there are disparities between those who identify as white and Black that persist at each level of the social vulnerability index. Here we looked at patients who were at low risk and high risk for things like food insecurity, housing insecurity, and transportation needs, and showed that those at high risk for these things were more likely to have their diabetes under poor control. So in conclusion, we show you today that social determinants of health and social vulnerability play a significant role in the well-being of our patients. They're a major driver of healthcare-related disparities. Racial disparities persist at each level of social vulnerability. Social vulnerability and race have an additive effect on diabetes control. And finally, if we're going to combat the diabetes epidemic, social vulnerability must play a central role in public health efforts as well as our clinical care. Thank you.
Great, thank you for that awesome presentation. We're now going to invite Dr. Umapathy Sivam to present.
Thank you for the opportunity to present our research entitled Serum Testosterone Age, Waist Circumference Glycemia and Risk of Incident Type 2 Diabetes. And I'm very happy to be presenting on behalf of my co-authors. These are my disclosures. Testosterone is the primary sex and an anabolic hormone in males. Clinical states of low testosterone are associated with reduced muscle mass and increased adiposity. Together, these are postulated to increase insulin resistance and type 2 diabetes risk. Whilst body composition is the predominant explanation offered in the literature, direct effects of testosterone on beta cell function have been proposed. A number of studies have demonstrated a reduction in diabetes risk associated with increased testosterone in different clinical scenarios, but it's unclear whether risk is impacted by baseline testosterone, i.e. is there a threshold at which elevation of testosterone concentration results in no further reduction in diabetes risk. The literature does provide an indirect assessment of this and whether there is a continuous linear relationship between testosterone and diabetes risk. And I'd like to draw your attention to 3 examples in the literature. The first is androgen deprivation therapy in prostate cancer, which acutely and profoundly lowers serum testosterone. When individuals receiving androgen deprivation therapy are compared to non-androgen deprivation therapy receiving cancer controls, there is a 1.4-fold increase in the likelihood of developing type 2 diabetes when followed for between 6 months and 6 years. Similarly, if we now move on to the second example, where a meta-analysis comparing variation in the normal spectrum of testosterone demonstrated that when you split those studies into individuals in the top 50% and bottom 50% of the testosterone spectrum, you see a reduction in risk of diabetes with a relative risk of 0.58 in those in the top half of the spectrum of the testosterone spectrum. Finally, and more recently, the treatment with testosterone for prevention of type 2 diabetes, or T4DM study, a randomized double-blind placebo-controlled trial, provided evidence of the impact of taking individuals with a low normal testosterone through to a pharmacological level of exposure. And in this study, testosterone treatment was associated with a 40% reduction in incident type 2 diabetes risk based on oral glucose tolerance test assessment at 2 years. So if we map those 3 scenarios out on this conceptual graph or image of diabetes risk in the testosterone spectrum, we can see that taking controls and moving through to profoundly low testosterone, as with ADT, increases your risk of type 2 diabetes. Similarly, if we move through the normal spectrum, looking at the bottom 50% to the top 50%, we have a reduction in risk. And then if we look at taking individuals with a low normal testosterone through to a pharmacological treatment dose of testosterone, we see again a reduction in diabetes risk, suggesting that maybe there is a relationship that persists throughout the spectrum of testosterone. However, not all study populations have demonstrated an association between type 2 diabetes and testosterone. The Australian longitudinal study of ageing did not demonstrate any significant difference in diabetes risk or association with testosterone, and the mean average age of entry into this study was 68 years. That's despite demonstrating traditional risk factors of type 2 diabetes as having an association. So the aim of our study was to assess the impact of baseline testosterone concentration across the spectrum of testosterone on diabetes risk and determine how this interacted with age, waist circumference, and HbA1c. We hypothesised that higher concentrations of testosterone would be associated with lower risk of type 2 diabetes across the baseline spectrum of testosterone, and that testosterone effect would be consistent across the range of HbA1c but may interact with waist circumference and age. To do this, or to address these questions, we examined the Men, Androgen, Inflammation, Lifestyle, Environment and Stress Study, or MAILS. This was a study of just over 2,500 men in metropolitan Adelaide, South Australia, who were aged 35 to 80 at time of enrolment and were followed for 20 years. During that time, they had baseline and interval assessments of demography, clinical measures, biopsychosocial measures, laboratory measures of testosterone exposure. We performed a multivariable logistic regression analysis to assess for the association of baseline testosterone concentration with incident diabetes at 5 years. We assessed for interactions with HbA1c, waist circumference, and age. We assessed for non-linearity using splines. The full model was adjusted for baseline age, waist circumference, HbA1c, family history, smoking, alcohol intake, and self-reported physical activity, as well as medication known to affect type 2 diabetes risk. Incident diabetes was assessed at 5 years after baseline. Assessment was based on the presence of an HbA1c greater than or equal to 6.5%, medication, the initiation of medication to lower blood glucose, or self-reported diagnosis of type 2 diabetes. Of the 2,500 individuals who were eligible for the analysis, we included just over 1,300, with individuals excluded mainly for diabetes at baseline assessment, missing data at either the baseline or 5-year assessment, history of cancer, or exogenous use of testosterone. 110 individuals during our study period developed diabetes, making up 8.4% of the population. Here I present the reduced model of our multiple linear regression. Included as cofactors are baseline testosterone, age, waist circumference, HbA1c, and family history of type 2 diabetes. All these factors were significantly associated with diabetes risk in the univariate analysis, and with the exception of age, these remain significant in the reduced model. As hypothesised, there was a significant and robust relationship between testosterone and diabetes risk, where a lower testosterone is associated with higher type 2 diabetes risk. Also of note in this model is the substantial effect of baseline HbA1c, with an odds ratio of 64 for every % of HbA1c elevation. In regards to interaction assessment, there was a strong interaction between age and testosterone and type 2 diabetes risk, with loss of association in the older age group. There was no detectable interaction in the relationship between testosterone and waist circumference or A1C. There was also no significant non-linearity detected in the effect of testosterone on type 2 diabetes risk, age, waist circumference, or A1C. This is consistent with our hypothesis of a continuous linear relationship. Alcohol, smoking, and exercise provided no additional predictive value and weren't included in the reduced model. Here I provide a graph to graphically demonstrate these associations. And on the y-axis we have probability of type 2 diabetes risk, and then represented across the x-axis our testosterone spectrum broken into discrete ranges. Within each discrete range is the progression of HbA1c from low HbA1c range, represented in the dark bars, through to the highest in the light bars. And what we can see, and if I draw your attention to the less than 11 group, is that as you progress from dark through to light, as HbA1c increases, you get an increased percentage, increased probability of type 2 diabetes at 5 years. Now that's expected. What is of biological interest and what we were trying to demonstrate is that if you follow any of those different coloured bars across the different spectrum, you see a progressive reduction in type 2 diabetes risk as testosterone increases. So regardless of baseline HbA1c or testosterone, you get a reduction with further increase in testosterone. Now that was in the 35 to 65-year-old age group. We saw no effect in the 65 to 80-year-old age group. So we don't see that same progression over the different concentrations. So the limitations of our study was that we had a low power to detect small effects with just the 110 incident cases of type 2 diabetes. Similarly, there may be missed non-significant, or interactions we would call non-significant, which were missed due to size, and similarly non-linearity may also be missed as a result of power. Finally, age may in fact be a surrogate of a non-measured factor, which changes with age. So the observation of no effect with age may in fact be representing something else. So in conclusion, higher baseline testosterone was protective against incident diabetes, independent of traditional risk factors, at all levels of testosterone in men aged under 65. This was true regardless of baseline HbA1c and waist circumference. This is consistent with recent observations that treatment with exogenous testosterone of individuals with normal or mildly low T reduces the risk of incident diabetes. We were unable to detect the effects of baseline testosterone concentration on incident diabetes in older individuals, those over 65. So finally, I'd like to acknowledge the contribution of our study participants, the co-authors, and our project funders, the NHMRC, and the support of the Freemason Centre for Male Health and Wellbeing based at the University of Adelaide. Thank you.
Okay, great. I'd like to invite our last speaker, Dr. Furman Martinez.
Hi, good morning. Thank you everyone for attending this conference. My name is Dr. Carlos Fermin and I'll be presenting my work titled Prediabetes as a Risk Factor of All Cause and Cause-Specific Mortality, a prospective analysis of over 100,000 participants without diabetes from Mexico City. So I have no conflicts to disclose. And first of all, we know that prediabetes is a well-known risk for development of diabetes and also cardiovascular events. However, there is a concerning lack of data regarding the extent and the magnitude of this association in low to middle income countries from Latin America, such as Mexico. And in particular, Mexico is a very important region for this topic because the prevalence of prediabetes in this country is very high. And it was estimated to be up to 27% in 2021. Furthermore, there are different definitions to establish if a person has or not prediabetes, and the definitions vary according to the test that is being used, for instance, HbA1c, fasting plasma glucose, or oral glucose tolerance test, and as well as the cutoff that is being used. For instance, if we focus on the HbA1c definitions, we have two different cutoffs that have been proposed so far. The one from the American Diabetes Association, which goes from 7.5 to 6.4 to define prediabetes, and the one from the International Expert Committee, which is a group of experts that was assembled in 2008, I think, and this group established the cutoff of 6.0 to 6.4% to define prediabetes. So we wanted to assess the magnitude of the association of prediabetes with different outcomes in Mexican participants. And to this end, we used data from the Mexico City Prospective Study, which is a study that uses information of over 150,000 participants recruited from 1998 all the way to 2004. These participants were followed up for mortality, both all-cause and cause-specific deaths, up to January of 2021. And briefly, we included in our study only participants who did not have diabetes at baseline, either diagnosed or undiagnosed, who had complete data of HbA1c and mortality, and who did not have any other comorbidities that could alter the associations with mortality, such as ischemic heart disease, stroke, cancer, etc. Lastly, we only analyzed participants aged between 35 to 84 years old. And the overall sample size was 115,919 participants from Mexico City. These participants were assessed regarding sociodemographic and health data with standardized questionnaires, and they also had an HbA1c measurement. And with this HbA1c measurement at baseline, we defined that participants had prediabetes with the two definitions that I mentioned earlier, the ADA definition and the IEC definition. And with this data, we used Cox models to assess the risk of mortality using rate ratios, and these models were adjusted for different parameters such as sex, age, municipality of residence, which is very associated with social vulnerability, education level, physical activity, smoking, alcohol consumption, and some adiposity indices such as BMI and waist to height ratio. And specifically, we studied if participants, if prediabetes was associated with premature mortality, which is defined as dying at ages 35 to 74 years old. Very briefly, what we found, first of all, is that prediabetes was very prevalent in our study. And the definitions and the prevalences varied according to the cutoff. For instance, in the left-hand side, you can see the prevalence of prediabetes according to the ADA definition, stratified by sex and by age groups. And you can see that the participants with the highest prediabetes prevalence were females, colored in blue, with increasing older ages. And the highest prevalence of prediabetes observed in our cohort was up to 45%. However, the overall prevalence in all of our participants was 26%, which means that in participants who do not have diabetes, up to 1 in 4 of them have prediabetes. However, when we studied the prevalence of the IEC definition, which is a higher cutoff, the prevalence was only 7%. Next, in very broad terms, we found that the risk of dying increases with an increasing HbA1c, which is not surprising. And you can see in these plots, first of all, the death rates, deaths per 100 person years of different mortality causes: overall, neoplastic, cardiac, respiratory, renal, cerebrovascular, gastrointestinal, and acute diabetic deaths. And you can see that with an increasing category of HbA1c from less than 5.7, sorry, all the way to greater than 6% in yellow, you can see that the risk increases gradually. And in the other side of this graph, you can see the rate ratios of dying of any cause stratified by, again, HbA1c category, but also by age group. And you can see that in all age groups, which are represented by each facet of the panel, the risk of dying due to prediabetes increases with increasing HbA1c, but in the older age groups, which were greater than 65 years old at baseline, the risk appears to be attenuated in these older ages. Lastly, when we examine the rate ratios and attributable risk due to prediabetes for all-cause cardiovascular, renal, and acute diabetic mortality, we can see some interesting things. First of all, you can see that for all of these mortality causes, the prediabetes defined by both the ADA and IEC was significantly associated with mortality risk. For instance, you can see that the risk of dying of acute diabetic crisis due to the ADA definition of prediabetes was 2.63, the rate ratio, which means that participants with prediabetes have a 2.63-fold increase in the risk of dying of this cause in the long term. However, you can also see that all risks are greater when we use the IST definition because the cutoff is stricter, which means that the IST definition may be better to capture participants who are at an individual greater risk of developing these adverse outcomes. However, when we observe the attributable or excess risk, we can see that the excess risk attributable to the ADA definition is significantly greater, and this is explained by the highest prevalence of the ADA definition. The attributable risk or mortality can be very broadly interpreted as the percentage of deaths that could have been prevented if these participants did not have the risk factor, in this case prediabetes. And again, for example, in the acute diabetic crisis, we can see that the attributable risk is 31%, which means that roughly 31% of participants wouldn't have died of this cause of death if they didn't have prediabetes at baseline. So to conclude, prediabetes was significantly associated with a higher risk of cardiovascular, renal, and acute diabetic mortality. The IST definition, as I told you, may capture subjects who are at a greater individual risk, while the ADA definition is associated with a greater excess risk due to its high prevalence. And none of this is significantly or particularly a breakthrough, but we found that we could significantly reduce premature mortality in Mexican population by identifying and treating prediabetes early on. And the novelty of this study and these results is that these have not been studied and quantified previously in Mexican population. Thank you very much.
Okay, great. We're going to begin the Q&A now. My colleague Jenny is going to take over. Just a reminder for anyone online, please include your name and outlet.
Hi, I had two questions for Dr. Sieber about some of the methodology. I was wondering if you could elaborate on how you measured taste sensitivity. You mentioned that there were like an increase in points, so I wasn't sure if how exactly that was measured. And then just asking about the biopsies, like when they were conducted, I assume at the beginning and then at the 16 end mark of the study, but yeah.
Okay, thank you for this question. The taste sensitivity was measured by 16 taste types of 4 different basic tastes of 4 different concentration. And for every correct answer, we marked as 1 point. So the altogether points were 16. And after intervention, we saw that the detection threshold for sensing the tastings at different concentration increased. Therefore, they sensed lower concentration of sweet, salty, bitter, and sour tastings after the intervention of with semaglutide. And this was expressed by these points that I mentioned as our result. And biopsy was conducted before and after intervention, and then the RNA sequencing was performed to assess the changes in expression of MRI for all the genes, and after multivariant analysis, those 5 genes stepped out that were included in taste perception of sweet and renewal and regeneration of taste buds, which is reported to be reduced and deteriorating in people living with obesity. So there were all the beneficial effects on taste gustatory coding.
Thanks.
Great, we have some questions from the online audience, from Jill Roulette at Endocrine Today. This one's for Dr. Jen Sterley-Silver. What is the presumed connection between the alterations in taste, gene expression, and brain functioning and weight loss? Is it that sweet tastes become unpalatable, for example? What about salty or fatty foods? Do we know whether these alterations persist if the person stops taking semaglutide?
It has been reported that semaglutide reduced the desire for salty, sweet, and sour food. However, our study was not designed to answer this particular question. We showed that that there is clinical detectable impact on gustatory coding, but whether and to what extent this is translated into clinical significance that we could connect with actual effect on weight loss, I think we cannot answer from this study, and we need newer design that will include the food diaries, the changes in food preference, the eating behavior, and the relationship between the change in taste and weight loss.
Great, thank you. For Dr. Tisch, this is also from Jill Roulette at Endocrine Today. More and more studies are showing that people with more social determinants of health and social vulnerability have worse health. What can we do with this information in the clinic, specifically in diabetes care?
Yeah, so I love this question. It's something that we're thinking about very much. I don't know that we have really a magic bullet that is going to really solve this in one fell swoop, so to speak. But I will say that this is something that we need to consider when we are thinking about our patients going forward. We need to think about social vulnerability and how we address that as a society to make an impact on the diabetes epidemic.
Great, thank you. Great. For Dr. Furman, what are some ways we could improve awareness and diagnosis of prediabetes?
So, throughout years, one of the problems with prediabetes is precisely that it's not as recognized and not as promoted as diabetes. So these kind of studies, although they are epidemiological studies, may be a call for attention to both the general public and to public health decision makers in order to let them know that we have to make greater efforts to promote and prevent this kind of risk factor. So some of the ways that they could use this information in order to improve prediabetes awareness are, for instance, a greater exposure in the media and greater prevention in the clinics, for instance, an expanded program for glucose detection, etc. So this is just some of the ways that could increase the awareness and the percentage of detection of prediabetes.
Great, thank you. Dr. Uma-Pathasubramaniam, why do you think testosterone may be having this protective effect?
We've got a few, I guess, clinical hints about why we might be seeing this effect. In one of our other presentations at this conference, we're presenting in Postboard 254, we look at the change in markers of glycemia across a 2-year spectrum in the treatment with testosterone for prevention of type 2 diabetes study. And what we see is that there is a non-significant compared to placebo, but a fall in fasting C-peptide, HOMA-IR and HOMA-beta, all of which are suggestive of reduction in insulin resistance. And compared with that, we also do some exposure to human endo-beta cells. And when they're exposed to graded testosterone, we see no increase in insulin secretion. So to take those two pieces of evidence together, as well as the association with changes in waist circumference and muscle mass, which are traditionally associated with insulin resistance, I guess we'd be saying that changes in body composition associated with testosterone therapy are likely reducing insulin resistance, and that individuals at high risk of progressing to diabetes don't have to produce as much insulin, so their diabetes doesn't occur within the follow-up period.
Great, thank you. I have one more follow-up from Jill Roulette at Endocrine Today. She asks, should we be measuring testosterone for men to assess type 2 diabetes risk?
So we actually looked at the predictive value of measuring serum testosterone versus taking a good clinical history, and we see no significant additive performance of adding testosterone into that model. I don't have the ROC curve numbers off the top of my head, but there wasn't a significant change. So taking a good history of all those traditional risk factors of type 2 diabetes should be adequate to, I guess, predict, and testosterone at baseline doesn't add anything to that.
Great, thank you. That's all the questions we have in the queue.
All right, we just want to say thank you again to all of our speakers and reporters that joined us today. As a reminder, the recordings of the news conferences are going to be available on our website and YouTube channel. If you have any questions or would like to set up an interview with any of our presenters, please contact us at media@endocrine.org, and I hope everyone has a great rest of their day.